Okay, welcome to Yale Cancer Center Grand Rounds. Today I'm very pleased to introduce two speakers who are both members of our Cancer Center faculty. We'll have two presentations today. First, I'd like to introduce Dr. Bonnie Gould Rothberg, who sits across the hall from me. She's a very nice person to have as a neighbor. In addition to that, she completed her MD here at Yale and followed that with an MPH and a PhD in molecular cancer epidemiology at Yale University, and she worked on molecular prognostic factors in melanoma for her PhD. She then continued working with Dr. David Rim as a postdoctoral fellow in his laboratory prior to joining the medical oncology faculty. And she is leading our efforts in the biorepositories for our the translational working groups, and in addition she's continuing her research on investigating novel molecular predictors of cancer prognosis. Today she'll be discussing her work with the Yale Lung and GI Biorepositories. So I'd like you to welcome Dr. Bonnie Gould Rothberg.
Well, Howard, thank you very much for that lovely introduction. And cutting right to the chase, I don't need to preach to the choir here about the new priorities in translational research. Now, Francis Collins has pretty much made this his bailiwick, trying to stimulate novel research pathways in translational medicine, moving findings from the bench to the bedside. To that, he founded the National Center for Translational Sciences in 2012. And in sort of thinking about the formal definition of really how do we enable translational research, one of the key linchpins of a translational program is having a ready archive of human and animal tissues that can be used for projects both prospectively and retrospectively. So here at Yale, the lung cancer program has had a similar vision for enabling translational research. And this dates back as far as 2005 when Frank Detterbeck joined the faculty. And one of his first comments was, gosh, we have this really robust surgical program. We have a tremendous medical oncology program. And how can we leverage our ongoing clinical practice to create a resource that will enable and facilitate translational research going forward? So he and Lynn engaged Susan Main, and for the next 3 years started talking about ways of how do we collect biospecimens, but not only collect biospecimens, how do we think about annotating them so that they provide a real rich resource for folks and not just a set of samples thrown in a freezer. So I actually formally joined the project in November of 2008 as I was transitioning from my PhD and looking for the next steps in my career. And basically, as a molecular cancer epidemiologist, the opportunity to get in at the start and the launch of a novel cohort was too irresistible. So I started working with Lynn in 2008, and by March of 2009, we submitted a grant to the Connecticut Department of Public Health proposing a multi-center lung cancer biorepository. Even though we didn't get the grant, and we're almost in a way thankful that we didn't, it allowed us to put together our thoughts on what would be considered as essential to moving such a program forward. And towards the end of 2009, I formally was given permission to start scurrying around and put together the infrastructure of what would then become the Lung Cancer Biorepository. In 2010, thanks to my mentor David Rim, I was able to take a field trip up to the Nurses' Health Study at Harvard and understand all of their structure and put together a Christmas list of all the things that we would want. Excitingly, our HIC protocol was approved in January of 2011, and Santa Claus arrived in March of that year when Gilead offered to throw in support behind what we were trying to launch. Our first patient was enrolled at the end of April of that year. By November, we were queuing up samples for whole exome next generation DNA sequencing through Rick Lifton in the collaboration with Gilead. In May of this year, we were able to get Yale Cancer Center institutional support to promote migration of our IT infrastructure to Encore, and excitingly, we were invited to participate in Roy Herbst's lung spore to help anchor the biospecimen core. So now here we are in December 2012. We have 2 dedicated full-time research associates. We have a dedicated storage facility that includes 80,000 sample capacity under liquid nitrogen, and we've altogether enrolled 278 patients. Briefly, the inclusion criteria for the lung cancer biorepository are adult patients who present to the TOP program with either confirmed or suspected previously untreated incident lung cancer. We'll also take folks who have newly recurrent, previously treated or untreated primary lung cancer when they do represent to Yale, and in a small select group of cases that are particularly interesting, newly progressive primary lung cancer, whether it's been treated or previously untreated, especially in working with the various attendings if there's a need to archive a certain patient given certain clinical criteria that are of particular interest. It is important to note that an immediate plan for tissue acquisition is not an inclusion criteria. So even if a patient is not an immediate surgical or biopsy candidate, we'll be more than happy to enroll them, follow them longitudinally, and be ready to capture tissue should that event occur in the future. When we first started, we were very proud of this very complicated workflow, and we thought that we must be important if we have to draw so many arrows on a page. But in the end, we realized that the real key to success is having a much more simplified workflow that is unified across all of our sources of enrollment. And what I'm going to do is talk a little bit about the key steps and components that have made us successful to date. So first of all, we've figured out how to have effective participant accrual. Our trick is that our biorepository staff is embedded within the top clinics. We love working with the faculty, and they've definitely been generous with their time, but if we wait for them to call us when there's eligible patients, we're going to be waiting an awful long time with the phone not ringing. So what we found is that the most effective way is to actually first attend the weekly tumor board meetings where new patients get presented and identify patients that fit our inclusion criteria. Then we'll review the daily EBIS or endobronchial ultrasound suite case list for potential candidates, and then proactively approach the attendings. So we show up at every single surgical and medical oncology clinic for TOP. And at the start of each clinic, we'll review all potential cases with the attendings and staff, go through the appointment list and say, well, are these patients, are these new patients, are these returning patients, who would be eligible, who might fit the inclusion criteria. And we pretty much hang around clinic waiting to get the opportunity to go in and consent the patient with the attending. We also have a weekly review of the upcoming surgical schedule. So in case a patient who had come into clinic, we missed them, we have an opportunity to recontact them on the phone before they actually go in for surgery. We also have instituted comprehensive clinico-epidemiologic annotations. So first of all, within 2 weeks of enrollment, all participants are interviewed to assess lifestyle behaviors, and we've done this using a suite of validated instruments. So in addition to collecting comprehensive family history, occupational history, medical history by interview, we're also assessing tobacco exposure using the Moravian-Winder instrument. Physical activity is assessed by the Gould questionnaire, asking patients for self-reported measures in the last couple of months of walking, moderate physical activity, and vigorous physical activity. We're using metrics to capture alcohol consumption, both current and at the peak of their alcohol consumption. We're also interested in continuous versus binge drinking habits. We are doing diet capturing using the Fred Hutchison Cancer Research Center Food Frequency Questionnaire, which was actually the instrument validated for the Women's Health Initiative study and is frequently used in many cancer epidemiology studies. And we capture quality of life measuring using the FACT-L questionnaire. We also review all staging diagnostic imaging scans and procedures with radiologists, and we code everything using a constrained vocabulary so there's consistency across all of the patients. We have a similar approach with the surge path records and our medical records, which are reviewed both at intake and at routine 6-month intervals for follow-up. We also have follow-up direct-to-patient interviews to recapture measures of lifestyle choices as well as quality of life. Next, going to biospecimens, we've really thought about the best practices for collecting and archiving our biospecimens. we collect 30 mils of EDTA-preserved blood on all patients pre-treatment. Because we want to make sure that all of our patients are having an awake blood, this one isn't necessarily fasting. The EDTA blood allows us to collect both plasma as well as buffy coat. And our plasma is extracted into 10 aliquots of 100 microliters, which is going to be our ultimate unit of distribution. And the remainder sample is put in 1.8 mil vials. And this ensures that any sample that we've distributed has undergone no more than 2 freeze thaws before the end user has to put his assay on it. Also, for the surgical patients, because we're going to be ultimately interested in possible measures of energy balance and other factors, we're collecting 20 mils of fasting serum at the time of placement of central access. For biopsies, for the EBIS, the mediastinoscopy, and IR biopsies, where a biopsy is really what's typically submitted to for clinical diagnostics, here our team needs to go to the bedside in the operating room suite. We work with Gaetan Michaud and Jonathan Pachalski in the EBIS suite, and as well as our 3 very capable surgeons, Dan Boffa, Tony Kim, and Frank Detterbeck in the mediastinoscopy suite. At the bedside, after the diagnostic specimen has been collected and submitted to cytology or SurgPath, we take up to 2 extra passes of the biopsy needle, provided the patient is stable and is consented. We collect a touch prep or cytological smear to confirm the presence or absence of tumor in that sample, and then the sample is put into RNA later for future use. We also have the capability to place samples in DMEM for cell culture, and we'll work with David Rim, who has his conditionally reprogrammed cell line program, to allow for the expansion of epithelial cell lines for basic research use. And you may see Eric Festa running around in and out of the OR suite, and he's our man on the street for that. For surgical specimens, where all samples have to go through the Department of Pathology for review according to clinical standards, we have a very active collaboration with Rob Homer, who is the head of the Thoracic Pathology Department, as well as Yalai Bai, who is the head of Yale Pathology Tissue Services. And we alert them each week for the upcoming cases of the week, and then they'll be the ones who run into the OR right at the time that the tissue is removed, bring it back to the gross room, very quickly work up all of the gross assessments so that within 45 minutes of cold ischemic time, we are able to collect samples for preservation. And this allows us to minimize some of the pre-analytical variables. We take 3 punch biopsies into RNA later. Touch preps are produced on all of those. 1 3-millimeter punch into OCT, and a 3-millimeter punch, and if there's extra tissue available, 1 centimeter squared block into formalin fixation for subsequent paraffin embedding. We selected the 3-millimeter punch because this not only standardizes units of tissue collection across all of the cases, but it turns out that this is the volume that maximizes fixative penetration while also maximizing the amount of tissue that we get. So people have actually done research and have shown that larger than 3-millimeter punch, the fixative doesn't penetrate as well to the core as quickly. And obviously, a less than a 3-millimeter punch, you are leaving some tissue on the table. And we've actually successfully recruited our first case from the St. Raphael's campus. We thank Dr. Nash and his team for wonderful response in allowing us to get a brain metastasis from a patient who's going to subsequently have a primary tumor resection. And finally, we have a link to all the residual tumor specimens that are in Surgical Pathology Archive, so we can join our data with what's held off in SurgPath. So again, if the tumor is too small to allow us to get a research specimen at the time of resection, the residual tumor that is on file can still be accessed for subsequent research. So with respect to sample tracking and storage, most people, when they think of biobanking, they think of writing information with a Sharpie on a cryo vial, throwing it in a -80 freezer, and storing that with Excel. And I think of that almost as the equivalent of the way banking was done in the 1920s, where you had numerous guys wearing visors, sitting behind mahogany desks with these green lamps. And what we're hoping to do is move beyond that and really think about strategies that will enable eventual CAP accreditation of our biobank. So first of all, we've replaced the Sharpie with barcoding, and all of our samples are labeled with a 2D barcode using informative nomenclature. Again, there's research suggesting that if you just have an 8-digit numerical barcode, that still allows for sample recording errors and allows for numerical errors in retrieving samples, and that it's more effective if your samples have some alphanumeric code that actually has meaning. So we've actually worked out a 2D barcode system where we make custom labels that actually include informative information on the patient, the HIC number, the type of sample, and what's actually in the tube. And we also maintain rigorous sample provenance that records all the handling, who's handled, at what temperatures, for how long, to maintain according to the CAP and ISBA accreditation standards. Next, we've replaced the -80 freezer with liquid nitrogen. And although there still isn't conclusive formal evidence-based research suggesting whether liquid nitrogen is in the long term more robust, many people have anecdotal stories about whether the liquid nitrogen does further slow down the degradation of nucleic acids and proteins in whole tissue specimens. But one of the points that really was hammered home, especially in the wake of Sandy, is if, God forbid, we do lose power, my liquid nitrogen tanks, when closed, will maintain temperature for a week, whereas a -80 will start coming up to temperature within about 12 hours. So as part of all of this, we do have an emergency preparedness plan, and the Friday before Sandy hit, we made sure all of our samples were secured in liquid nitrogen. Finally, we're very excited that we're replacing Excel with Encore, and grateful to the Yale Cancer Center and to the YCCCI with Hank Duravage and Tisha Johnson, who've allowed me to work with the folks at Forte Corporation to be able to bring our samples into the Biospecimen module and all of our clinical information into the Unified Registries module. Hopefully we'll be going live with that by the first quarter of next year. So how well are we doing? Mentioned that we've been active now for 19 months. We've overall recruited 278 participants. The majority of our patients are coming through the top surgery department. And again, this really reflects that we are still trying to maximize patients with tissue, and the majority of patients who are going to have a tissue procurement opportunity are patients coming in for a resection. We also have great relationship with the folks doing EBIS, and we've recruited 39 later stage patients who are coming in for a biopsy assessment. We've gotten 36 patients through our medical oncology colleagues. And these are patients newly diagnosed, typically stage 4 cancers coming in for chemotherapy. We've managed to get 9 patients through the inpatient arm, which is actually a really exciting opportunity to work with the internal medicine residents. Patients sometimes will present to the emergency room complaining of chest pain, complaining of shortness of breath. They'll get a screening x-ray, and there'll be a lesion noted on x-ray or CT scan. And before the medical oncologists even get called, a biopsy needs to be performed. So we've been trying to work with the medical residents to have them contact us when these patients come in, if it's suspected to be a primary lung cancer, so that we can go to the CT-guided biopsy and get a bit of tissue. We've had a few patients come in through radiation oncology. We have this avenue open, but recognizing that this really isn't the primary modality that patients with new diagnoses of lung cancer are coming into the system. With respect to the surgical cases, now that we can review weekly the pending OR lists and approach the patients, we can figure out, are we able to get 100% ascertainment? And we've actually done pretty good. We get about 80% overall of all of the surgical patients have agreed to consent. More excitingly is that in the last couple of quarters, we've eliminated missing patients, patients that we just didn't know about that we could have gotten, and the lines of communication gotten crossed. We also learned that if we approach a patient to consent them for the first time the morning of the surgery while they're waiting in the preoperative holding area, even if the patient is willing, there's usually one or more family members who are just anxious about the overall procedure and don't want to talk to study staff. So we found that approaching folks on the phone, if we did not get them in clinic, talking to them about the study, getting their interest, and if they're potentially interested, finishing up the consent process at that time in the OR area allows us a higher rate of success in those patients that we weren't able to approach in clinic. And this is the brief distribution of the participants that are in the biorepository. As you can see, the majority of our patients have been typed as having an adenocarcinoma. We have about an equal amount of patients then with squamous cell carcinoma and other histologies, which include small cell, large cell, adenosquamous, and non-small cell lung cancer not otherwise specified. This is usually a category that is determined based on a small biopsy sample where you can clearly say it's lung cancer, but you're not sure of whether it's an adeno or a squamous histology. We've also got 4 carcinoids and a couple of patients with synchronous primaries where both primaries aren't of the same histology, and we've categorized those as other histology. Note that there's 11 patients where the pathology and analysis is still in process, and they haven't been included in this spreadsheet. Interestingly, we have more or less equal distribution of patients across all of the stages. Among gender, there's a higher proportion of females in the adenocarcinomas. Race, you can see, although racial groups are relatively equally represented across all of the histotypes, the majority of our population is biased towards the Caucasians. We do have patients at all spectrum of age. There is a small increase in younger patients in the adenocarcinoma group, although this isn't statistically significant. But you can see the trends for smoking, whereas we have very few squamous cell carcinoma patients in the never or very sparse smoking patients, whereas there's a higher frequency of adenocarcinomas and some of the other histologies in this category. About 100 patients have undergone clinical somatic mutation profiling. Obviously, the majority of these are adenocarcinoma patients, and we've had some others undergo the procedure as well. And you can see here we have a distribution of mutations that is typical of what's been reported in the literature. We have a spectrum of EGFR, KRAS mutations, as well as 1 BRAF, 1 HER2, and 35 of the patients that have undergone the clinical typing in Zenta Walther's lab have come back as negative for the panel that she's testing. 64 additional cases have been submitted to the Yale Gilead program for whole exome analysis. Currently, there's data available on 59 cases. I've actually been able to have the opportunity to do some exploratory analyses on 35 cases, and not to steal the thunder of David Rim, Rick Lifton, and Murim Choi. I'm just going to report at this point that there is a huge variation in the number of somatic point mutations detected in each of the samples. Some have fewer than 10, while others have greater than 600. And the one thing that I found striking is that this really wasn't significantly correlated with the self-reported smoking history. So we have some patients with very few mutations and non-substantial smoking history, so like greater than 20 pack years history of smoking with a very small limited mutation profile, and the same vice versa. Mutation frequencies in our 64 set do reflect literature trends. So for example, 17 of the 35 patients had a p53 mutation. So this is our up-to-date accounting. Looking across stages, we've got about 750 different frozen biospecimens that occupy about 6,200 cryovials that are already collected and stored under liquid nitrogen. Another 142 participants have an FFPE block that's available in surgical pathology, and we've completed 730 case report forms on all of the patients enrolled. But don't curbside me in the hallway with respect to getting samples out of the bank. We actually have a governing board that will be accepting applications soon enough for sample requests. And our expected protocol will be that folks will need to submit a robust research protocol complete with power calculations, hopefully preliminary data suggesting the robustness of the assay and the translatability to our sample set, similar to what people would require for requesting data out of large cohort studies or cooperative group clinical trials. Personally, again, going back to, well, Bonnie, why did you get involved in this in the first place? My own research interest is really in focusing in cancer survivorship in those for whom cure is possible. So for example, for non-small cell lung cancer, looking at the survival curves that were underlying the 7th edition AJCC staging, you can see that, stages 1A and 1B, the overall 5-year survival despite curative intent resection still approaches close to 50%, and stage 2A and 2B is a little less than 50%. Bear in mind, though, that in this setting, still, adjuvant chemotherapy is not recommended for stages 1A, pretty much not recommended for stages 1B, although there is a clinical trial that showed possibly some benefit in the 1B patients with tumors greater than 4 centimeters. Stage 2 has an unequivocal benefit of platinum-based adjuvant regimens, but clearly still the mortality is significant, and these are patients who underwent curative intent resection of their cancer. So I am interested is, can we not only, and my research thinks about, can we not only identify molecular signatures at the time of diagnosis for the subset of tumors that have the highest risk of recurrence and selectively maybe treat those with adjuvant treatment so that we can maintain an overall high-risk benefit ratio for adjuvant, so we're not putting patients at risk who are likely to be cured from the surgery. And at the same time, for those patients who qualify for active surveillance, are there lifestyle modifications or other interventions that are non-pharmacologic that we can introduce into these patients? So what I've been doing is I've been following the stage 1A, 1B patients with who've had a curative intent resection, and part of that is my motivation for collecting all of the lifestyle factors and doing all of these longitudinal assessments. So to date, we have 80 of these folks, and looking at their overall distribution is really independent of the different stages, different T stages. And as this cohort is maturing, we now have over a year follow-up on 38, 27 have 6 to 12 months of follow-up, and 15 are newer patients, and we've already logged 3 recurrences in this data set. So over the coming years, as this set recurs, as this set grows, as this set matures, for me, that's going to be really where I'm hoping to build some of my research. And of course, one good turn begets another, so I'm grateful to Howard Hochster and his confidence in what we've done in lung to start up the Yale GI Cancer Biorepository, and in collaboration with the Hickson Pancreatic Cancer Gift, and again, Gilead, we've assembled a team of medical oncologists, surgical oncologists, surgical pathologists, epidemiologists, and Dr. Slanian, who does all of the EUSs on the pancreatic cases. And to date, we've now, since launching in May of 2012, we've already enrolled 81 patients with GI cancer, literally going from stem to stern, right through the GI tract. And Carol Domini in my lab is the person who is coordinating this effort. And finally, again, we're starting to get noticed for our capabilities. Laos Pustai has engaged us to work on the Yale Breast Cancer Translational Biobank. He's got a slightly different model. Rather than prospectively collecting biospecimens right across all newly diagnosed breast cancer patients, he already has a suite of translational projects ongoing, and he is having us manage and annotate the biospecimens that are collected in the context of these focus hypothesis-driven translational studies. Lynn Tanui's been working with me, with Amanda Reed and Gaetan Michaud on the lung screening and nodule program, and we already have 5 patients enrolled in the SCAN biobank. And finally, I've been, as Dr. Yarbrough likes to say, minding the store while he unpacks his laboratory, and I've been supporting Bed Judson and Michael Otremba as they launch their head and neck biobank. So with that, I'd like to thank the whole cast of characters that I've been working with over the last 4 years, the folks in my lab, all the wonderful people in the TOP program, the GI cancer program, head and neck, breast cancer, Yale Pathology Tissue Services, and a brief shout out to the folks in the genitourinary and lymphoma biobanks that we've been in discussions with to launch things hopefully in 2013. So at this point, I'll take any questions.
Thank you very much, Bonnie. That was an excellent overview of where we're going. Do you have any questions?
That's great. I have a question about, so it looks like you have a governing board for to acquire tissues. What about, how does one acquire sequencing data information?
So that's a good question. So Dr. Sweezy wanted to know, how do we request out the sequencing information? And that's actually going to be interesting because we really haven't quite figured out the right way to do that yet. Obviously, we have a set of 64. And when you start thinking about doing studies at a whole genome level, which is really what exome sequencing is going to force you to do, you need p-values of 1 × 10⁻⁸. So you put that in perspective, and a set of 64 is almost like, well, that's a nice start, but really what are we going to do with that? So, Rick was nice enough to give me some summary data that I can play and make some associations for this talk, but they're really not prepared to release the data until we have a larger sample set, until we've really gotten under the hood, figured out the data analysis, and have actually put together the infrastructure of how we're going to move all that forward. So I think we can touch base again probably later in 2013, but I think a lot of that is still under construction. And we've got about another 100 samples that can go to Gilead, and we're just waiting for the green light of when they're ready for us.
One thing that I think distinguishes this program from many other biobanks is the epidemiologic connection and the amount of time and effort you're spending on that. So, and I think that reflects your interest as a molecular epidemiologist. So can you give us an example where you see some utility of that kind of connection between the tissue and the epidemiology? I mean, personally, I'm thinking of a report recently on the glycemic index and the recurrence of colon cancer, but how can you use this information in that way? So
again, that's a great question. Really what we'd like to think about is breast cancer is probably the best example, because overall the breast cancer research community has already been thinking about metrics for prognosis for the last 8 to 10 years. And they've shown that heavy-set women, for example, are more likely to recur with their breast cancer in spite of a curative intent regimen, and that if you maintain or even lose weight and engage in regular physical activity as a breast cancer survivor, that will improve your overall prognosis. Now, that doesn't mean it's going to work for every Mrs. Smith and Mrs. Jones across the desk from a clinician, but overall at a population level, maintaining a healthy weight, engaging in physical activity has been shown to improve survival. Interestingly, associations with lifestyle factors aren't as well established, for example, in melanoma, where I do a lot of my research, or in lung cancer, as I'm presenting here.
But how would you tie that together with the tissue?
So really what I'm interested in doing is creating these comprehensive models. Survival isn't going to happen in a vacuum. Obviously, lighter women in breast cancer with a more aggressive tumor type aren't going to have as great a survival outcome as women of the same body mass index and a more indolent tumor type. What we also don't know are the interactions, are the combinations of having a heavier set and more aggressive tumor type greater than the sum of the parts. And this is where having robust epidemiologic information as well as molecular information will allow us to look at the gene by environment interactions. And this is now one of the coming trends in molecular cancer epidemiology, is once we get genome level information, genetic variants, somatic tumor mutations, now being able to think about how do we survey the environment and how do we assay the gene by environment interactions.
Okay. Well, thank you very much for that outstanding presentation and all the exciting work that's happening here with the biorepository efforts in lung cancer and other cancers coming up.